It's my pleasure to serve the community, and more particularly in this way, in a topic that is one that is close to my heart for those who know me. So my presentation today, I'm asking us the question, is ethics a private matter? And my aim is for us to appreciate the significance of ethics for satisfying practice outcomes. We will look at, I will just list the principles of ethics, which I know that we all know, but I thought let's just go back to that basic foundational information first. And then I will discuss the role of ethics in factors that influence clinical decision-making. And I will discuss the topic, what is called a 4-topic approach in ethical clinical decision-making. And then we will apply this approach in analysis of clinical cases. So we are actually going to be practical in my presentation in this 1 hour or just under an hour. We will break out into 4 groups, and Tawanda will assist us with that. So just going back to basics, just that foundational information that we need to remind ourselves as we go through this session are the 4 basic principles of ethics. The first one is beneficence, not particularly in any order of importance. They are all equally important, but beneficence is about doing good, beneficial things for your patient. Non-maleficence is doing the patient no harm. Autonomy is respecting that the patient is an individual in their own right, with their own attitudes and their own opinions. And under this come the 2 very common concepts of ethics that we know, and that is consent and confidentiality. And then there's the principle of justice, and this is to do with fairness to the patient and to others. So these are just a recap of those principles, those 4 basic principles that we are going to use as we do the practical aspect of my presentation this evening. So as clinicians, clinical decision-making is core to the work that we do. I sometimes say to students, if we were able to operate or function like car mechanics, where patients would just come in at the reception in the morning and say, I booked my mouth for 8 o'clock, and they drop off the mouth and off they go to carry on with the rest of the day. And then they come back and pick up their mouth with the tooth done at 3 o'clock. I guess life would be so different from the way it is now. So patients come in their entirety, and there are factors that influence the treatment planning when we attend to our patients. The first one, of course, being the state of the patient's oral cavity, which is the primary reason that they've come to see us. But the patient's level of understanding of the diagnosis and its prognosis have a big part to play in our clinical decision-making process. The patient's attendance patterns also influence our clinical decision-making. I have there an example of a patient who comes once. You have them in your system and they show up every 5 years or so. Patients like that will influence your clinical decision-making, because when they come and you see a deep fissure that is kind of questionable, your decision of whether to monitor it and just keep an eye on it, or to actually do a preventive resin restoration, is influenced by that patient's attendance pattern. The values for oral care for that patient, is it aesthetic or is it health-based? And then the patient's financial abilities. And let me say, colleagues, that variation happens. in clinical setting. We will make different decisions when we are faced with identical cases sometimes. And this is underpinned by the various principles. So let's remember that it doesn't necessarily mean that you and I will make exactly the same clinical decision in terms of a treatment plan on the same patient. There may be slight variations, but they should still be within the norm of science, of what we have been taught and what we continue to learn. So having said this, there are some red flags that for a clinical case that make the clinical case and our decision they increase the risk of this being an ethical problem. So I just listed 4, but they may be more than that. But the 4 main ones are the disease factor, the factors that the patient has come with, their condition of the oral cavity. They may have multiple conditions. There may be one condition that is in a severe state of disease. There may be in extreme pain. It could be issues of finances. And with finances, not necessarily that they don't have or they have too much. Both aspects can be red flags for an ethical clinical problem. It could be people issues. Some patients come in their own states. They have issues. They are dealing with other things in their lives. And when they come to us because the tooth is aching on top of everything else that they are dealing with, they may not come through as an easy person to deal with. So some patients tend to be rude, others tend to be imposing, particularly when you are a younger practitioner and they are older, they tend to be imposing. Some tend to be demanding, and there are some who are just simply attention seeking. And then the expectations as well. Some expectations are unrealistic as far as the aesthetics is concerned, or even as far as function is concerned. So the reason it's important to keep these factors at the back of our minds when we are attending to our patients is that these 4, and there may be more, these issues that I've just pointed out, they function as red flags. The more these factors present together in one patient, the greater the potential for ethical problems. So what I'm saying is when we do have patients who come and we notice that this is a patient in extreme pain, this is a patient whose condition is just severe, late presentation, or goodness, there's so much going on in this mouth, there's multiple caries, there's perio, there's missing teeth, everything is just happening in this patient, plus their own medical condition. They have in their history, there's a whole lot that you've listed, plus these medications. So when you have patients like that, it's red flag. It means that this patient is very different from a straightforward case that comes in and they say, Doc, my tooth is starting to be sensitive. I thought, let me just have it checked out. Or Dr. Makoni, my filling, I was eating something, I chewed on something hard and my filling broke. They are straightforward, they are pleasant, they're not carrying any baggage with them. These are different from the red flag cases that I've listed here. So when we have such situations, it is important to then put on your clinical ethical thinking cap. Put it on, we must always have it on, but it's almost like deliberately refer to it and start thinking and planning and communicating with this patient, bearing in mind that this is a potential issue that may raise ethical problems. And therefore, I need to deal with it with that extra effort and the extra time. So many models are available for dealing with clinical cases which may be ethical problems. There are many models that can be used. I am going to share with us this evening a model that is called the 4 topics approach for decision making, for clinical ethical decision making. And this approach speaks to looking at 4 areas when a patient presents to us, particularly when they have those red flag issues that I've just spoken about. So these authors, they recommend looking at the medical indications, looking at the patient preference, looking at quality of life issues, and then looking at contextual features. So what I'm going to do is I'm going to just quickly run through what these factors mean, and then we are going to break into 4 groups. There are clinical cases that each group is going to look at. I'll give us 15 minutes to do that, and then we'll come back again into the bigger group, and so that I can have the last 10 to 15 minutes to put everything together. So when it comes in of the 4 topic approach, the medical indications are speaking to issues to do with the history, the diagnosis, the prognosis. Remember, at the back of our mind, we've got the red flags, and at the back of our mind, we also have the 4 principles of ethics. So when we look at the medical indications, we are thinking about history, the diagnosis, the prognosis. Is there something that is popping out, something that seems to be more significant than your usual? And I may also refer to Dr. Manana's lectures that he's given us in the 2 series. This is where this fits in. You're looking at this patient has come in pain from an impacted wisdom tooth, and you're looking at this and saying, okay, how impacted is it? How serious are they in pain? What is the prognosis if I am to do an extraction? Is this acute? Is this chronic? Is this reversible condition that the patient is presenting? What are their goals for treatment? Some will actually come and say, I'm in so much pain, just please get this offending tooth out. I failed to sleep. Another one may actually say, I'm in a lot of pain, but I don't want to lose my tooth. Doc, can you do something about it? So what are the probabilities of success? And again, I'm going to take us back to Dr. Manana's lecture, plus the one we had yesterday, the probabilities of success. Do I have enough of the clinical skill and knowledge to attend to this particular problem? Can I actually, am I trained enough? Am I skilled enough? Do I have the correct equipment and instruments to do the type of procedures we saw yesterday in yesterday's presentation? So what are the probabilities of success if I just delve into it? What are the plans in case of therapeutic failure? So in sum, when it comes to medical indications, you're actually saying, how can this patient be benefited by the dental care, and how can any harm be avoided? Colleagues, I want to keep stressing this process should be applied when it comes to situations where the patient, you pick up those red flags. So patient preference, what is the patient stating about their preference for treatment? Has the patient been informed of benefits and risks? Have they understood the information? Have they given consent? And the whole subject of consent is for another day. Maybe we can arrange for that for another session, another lecture. Has the patient expressed prior preferences? Is the patient unwilling or unable to cooperate with treatment? And if so, why? So in sum, is the patient's right to choose being respected to the extent possible in ethics and law? That's what you are processing at the back of your mind as you are attending to this patient in the initial stages before you make your final recommendation and discussion with the patient. So the other two of the four topic approach is quality of life. What are the prospects with or without treatment for a return to normal life? Are there any physical, mental, and social deficits that this patient is likely to experience if treatment succeeds? It's an interesting question. Are there biases that might prejudice the provider's evaluation of the patient's quality of life? What kind of biases could these be? What is the patient's financial position, for example? What is my financial position at the moment? Is this the only patient I've seen the whole week? So am I having already a bias to wanting to do everything possible to get money out of this patient? Is the patient's present or future condition such that his or her continued life might be judged as undesirable? Is there any plan and rationale to forego treatment? And are there plans for comfort and palliative care? So the last of the four topic approach is the contextual features. Are there any family issues that might influence treatment decisions? And you will see some of these will apply in the clinical cases that we are about to look at. Are there provider issues that might influence treatment decisions? What about financial and economic factors? What about religious or cultural factors? Are there any limits on confidentiality? Are there problems of allocation of resources? And how does the law affect treatment decisions in this particular case? And is there any conflict of interest on the part of me, the provider, or the institution if you are working under an institution setup? So colleagues, here are the cases. I'm just going to, we've got about 2 minutes before we break into the groups. So I'm going to just run through these cases, and then you are going to work through the cases using the framework that I've just presented. So the first case is a 66-year-old man, retired, and he wants all his remaining teeth removed to have full dentures. So the patient wants all his teeth removed because he has now saved up for dentures. He has had problems with his teeth and he has had numerous extractions. The history shows reason for multiple tooth loss was poor dietary and oral hygiene habits, leading to gross caries and late presentation and subsequent multiple extractions over the years. And he says life will be easier without his natural teeth, which might decay and hurt, although at present, none of his teeth hurt. So he just wants to be able to eat steak again. He has never had dentures before because he couldn't afford them, even though he has missing teeth. And his food options have become more and more limited as he has lost more of his teeth over the years. And his previous dentist put fillings on the front teeth and refused to extract them. On examination, the patient has maxillary incisors and canines, all with discolored composite restorations, but no pulpal involvement. So the remaining teeth in the mandible are 3-6 with an MOD amalgam, but it has distal secondary caries. 3-5 is healthy, and 4-4 has occlusobuccal caries. So some of you are going to be in a group to work through what you would then do with this case. The second case is a 6-year-old girl with painful tooth. The mother brings her. She has been in pain the last few days. She didn't sleep at night due to the pain, and the mom noticed swelling around the lower right back teeth. She has also previously complained of pain when she's chewing on the upper left side. So when you examine, all her deciduous molars have gross caries and they're swelling around 8-5. She also sucks her thumb and The mom is concerned about her teeth not closing in the front. She's also worried about what appears to be a tooth coming out in the bottom from behind another tooth. So the daughter is anxious and refuses to sit in the chair until the mother promises her sweets if she sits and opens her mouth, to which she cooperates. The mother says they are on a new US dollar medical aid scheme, which will only become valid next month. So she asks you to post-date the claim, as she has no money to pay cash for the treatment now. The third case, 55-year-old lady preparing for her daughter's wedding. She's not happy with the color and size of her teeth. She wants her teeth to be really white and to fix her front teeth that are getting shorter from chipping off at the edges. She wants the perfect look as mother of the bride on the wedding pictures. The wedding is in 2 weeks' time. Her daughter is concerned about those ugly teeth, which might spoil the pictures. The patient tells you that money is not an issue, as her rich husband will pay for the treatment because he wants to please his darling daughter on her special day. And the last case, a 45-year-old man with pain from the upper right molar, especially when he's eating. Tooth is loose and he's getting more painful. On examination, he has generalized periodontitis and halitosis. He tells you that he does not frequent the dentist because x-rays and local anesthetic are not good for anyone's health. He believes in herbal therapy. He's taking herbs and uses herbal toothpaste to treat his gums. And it has been working all these years, as he still has his teeth, even though they are somewhat loose. This time, however, the upper right tooth is not responding to his home remedies, and that is why he has come to you. He's also annoyed at people who are fussing about COVID-19 when it's just a flu. He's angry that he has to wear a mask and avoids wearing it as much as possible. So he's happy that he can take it off for you to examine him. He also states to you that he will not take the vaccine. He also doesn't want his tooth extracted. Okay, colleagues, so these are our 4 cases. I'm going to ask Tawanda to put us into groups. And in each of the groups, there's a key person there who has the case to read out to you and the framework. You will have 15 minutes to discuss through the case and choose one person in that group who will report back, just give us a brief summary as a report back. Okay, so Tawanda, are you ready to put us into groups?
Yes, go. Let me just. Hello, for the.
Are we all back?
Yes, we are back.
Yes, we are back.
We're all back.
We want to go
I think
back.
there are some people who are still
We want
in
to
their
go
room, in the breakout rooms.
Was that 15 minutes?
Yes, it was.
Oh dear.
The time was short. Yes.
Yes.
Okay, so as I was looking at it, 15 minutes is not a lot of time. And maybe Dr. Vicky and her team will consider us having another session at another one of the lectures to do some more of this. So I'm not sure how disciplined people will be and how quickly people will be to give us their just a quick 2-minute summary of what your group came up with. So can I have case 1? That's the 66-year-old. Just point out the key things that you look at as these were red flags, and therefore it's a case that you need to spend time on and look at all the ethical threats so that you manage the case without any problems as far as ethics is concerned. So case 1, please, whoever was the rapporteur.
Thank you. For case 1, I think we had a 66-year-old man, partially dentate with multiple anterior fillings, old composite restorations, and some failures. I think he only had 3 posteriors left, according to, sorry, we don't have the thing at hand. And the issue was he wanted all his teeth taken out for partial dentures, and his previous doctor had refused to have to take his teeth out, and he was saying, oh, I've got savings for a complete denture. So basically we looked at it, the medical indications, basically how best can the patient be benefited by our dental care. Our treatment plan and prognosis was leaning towards partial dentures and redoing his restorations, the anterior ones, and fixing the secondary caries and also the occlusal caries on the other teeth and giving him a partial denture. That was our option. His preference basically was to have complete dentures, and we felt that ethically, it was not ethically right for us to be able to provide him with complete dentures. And if we were to look at the quality of life aspect, we felt that he would have better quality of life with his partially dented mouth and restorations redone and a partial denture in place, as opposed to having a complete set of dentures. And then also other contextual features that would have influenced treatment decisions. In the background is most likely his age, but also the fact that he was mentioning, oh, I have savings. That can be an ethical issue if finances end up driving the decision on what is best for the patient. So that's basically, that's where we were before we got cut off.
Okay. Okay, thank you. You've summarized it very well. Can you confirm, colleagues, can you see my slides still? I've got case 1 on.
No,
are we
just
seeing that?
We can see you. We can see you, Doc, not your slides.
Okay. Okay, so thank you for that quick summary. And indeed, you highlighted the key issues, the red flags. If you had succumbed to if you go along with the patient's request, you are now looking at violating do no harm. You are doing non-maleficence to take out those anterior teeth. You are going against the beneficence and the non-maleficence. So you've got to spend time educating the patient, talking to them about the pros and cons, and really involving the patient in the treatment plan. So autonomy is important so that they consent, they understand the prognosis that you are doing this for their good. And I like the issue that you raised, beware of the finance, so that it's not driven from your side on the finance issues. We do need the finances, but beware when finances become the driving factor. So thank you, group 1. Can we have as quick a summary as well from group 2? Let me put the case. So don't worry about saying the case if others can see it on my slide. Just tell us what your red flags were and how you would summarize this.
Hello,
somebody from
Dr. Makoni. I was obviously, like you said, you put the case up. You haven't yet, but in just summary, the 6-year-old.
You can't see it. Okay, go on.
It's the 6-year-old child that comes in, and we definitely came up with the conclusion that it's a strong medical indication for seeking treatment. But unfortunately, there is a lot of red flags with this with this patient. One, the mom brings the child only when they are in pain. They bribe the child also with the wrong thing. They have a medical aid which hasn't kicked in yet, and they're already asking you to defer or rather to charge them after you've made the treatment. So what we came up with was that maybe, yes, the child does need treatment. So it's either we agree to treat pro bono or just the emergency, at least to relieve the pain. If it's not pro bono, at least to do a treatment plan. But also the question is, will the mother come for the treatment, for the payment? That we are not sure. So unfortunately, we're discussing quite a few things with this child before it cut off. But there's a lot of red flags.
Sorry, Dr. Dudu. Hi, we might get cut. I might get cut. I'm just hearing my generator straining right now. I think something's happening. But please do carry on to the next case. If I do get cut, go on to case 3. I'll be back on just as quickly as possible. So please do go on.
Okay, and just the last thing I wanted to say is that we also say that the patient, or at least the mom, needs a lot of counseling in terms of oral hygiene, instructions for the child, and also diet. Then we got cut off. So maybe the next case. Thank you.
Okay, we can go on to the next case. Case 3.
Okay, so for case 3, it's Dr. Chikosi. We had the lady who is a 55-year-old lady who was preparing to go for a wedding, and she was not happy with the color of her teeth as well as how short they had become over the years due to the chipping on the edges. And her husband had enough money. Is a rich husband who was willing to pay for all the work as long as the pictures came out good, according to the daughter and the husband. So following the approach, we felt that for the quality of, sorry, where's the first one? For the medical indications, we felt that there were no contraindications for actually doing the treatment. However, the time frame to do prosthetic work on these patients would not be ethical for us to be able to accomplish what it is that they were requesting in a period of 2 weeks. So apart from the fact that it is possible the treatment could be done, but the problem is that in the time frame that she needed it, we could not satisfactorily achieve what it is that she wanted. As far as patient preference, the patient obviously preferred, well, she didn't really state what it is that she wanted to, but she just wanted a tip fixed. So though the patient's preference was to get this work done within 2 weeks, some of us felt that the wedding had been, planning had been going on for several months, and she should actually have sought treatment earlier than that. And then the doctor also has the right to then offer minimal treatment, but not complete the treatment because they have the right to deny based on their ethical and laws that apply. So we felt that we couldn't achieve what this patient actually would require in 2 weeks. And then for the quality of life, we hadn't gotten to the quality of life, but I think one of our participants said that it would obviously they were going to start, for example, doing bleaching, but bleaching would not actually fulfill everything she wanted. So there were plans to do something for her for comfort and palliative, but they couldn't fully achieve what she desired. And for the last one, the problem, for the quality of life, I think the other thing that would also, there could be possible prejudice if we looked at the fact that the husband actually had a lot of money, and if we went by the fact that if we needed money, if we went ahead and did it just for that, then that would actually not be ethical to do. And for the last contextual features, the factors that would influence that would be obviously the finances. The patient had enough finances to be able to go on with the treatment, although it was unethical for us to then do it because it wouldn't obviously fulfill what it is that she wanted. So that's for question for case 3.
Okay, thank you, Dr. Chikosi. So Dr. Makoni dropped off. She's just fixing their Wi-Fi. So she has asked that we take a 5-minute break so that when the fourth case is presented, she's back on. So we're going to take a 5-minute break right now. And then after that, we'll continue through her lecture and then Dr. Makoni's lecture. So from now to 6:05. So the fourth case can present when we come back. Thank you.
What is it?
Okay, Doc, I think we can continue.
We're back? Okay. All right.
Yes.
So Dr. Chikosi, thank you for sharing your case on behalf of your team. I was listening through Dr. Vicky's phone, so I got, I think we all got the red flags that you pointed out. So we'll just go straight on to the fourth case. I don't know who that was, just 2 minutes to share. That was Dr. Kumbawa's team. So case 4.
Vimbai will take it.
Okay.
Hello, Vimbai, are you there?
Yes, I'm here. Good evening, colleagues.
Evening.
Our case was case number 4. Unfortunately, we didn't get enough time to do justice to the case, but I'll just present the few things that we managed to point out during the time allocated. The way we tackled the case was firstly to list the negatives that the patient presented with, because he didn't want to have the tooth extracted. And he's a patient who has a history of not just wanting to have a vaccine as well. And then he also uses herbal treatments, and that has been working well for him. So in terms of the treatment that we proposed for the patient was to have that tooth extracted, but as I had already mentioned, this patient would probably not consent to have that tooth taken out. And that would definitely go against the ethical principle of informed consent that you mentioned earlier. And then at the same time, in terms of managing the patient, since they don't want an extraction, we opted for pain relief, which will just be antibiotics and painkillers. And this is a different option to the herbal treatments that this patient has been using. So that should work effectively in our view. And then hopefully after the patient has gone back home, in case the antibiotics don't work, they'll probably consent for the treatment that the doctor would have prescribed, which is the extraction of the tooth. And then in between the antibiotics and the thought process of the patient, we decided that we'd also refer the patient for counseling, probably so that they are able to accept the doctor's prescription in terms of the extraction of the tooth, not for the patient to decide what the doctor should do for them. And then in terms of the other issues, in terms of oral health, we'll probably give oral health instructions for the patient so that they can be a regular dental visitor, so that their mindset can change. Instead of using the herbal treatments, they'll also allow the dentist to actually do their work the way they know best. And then in terms of the quality of life, after the antibiotic prescriptions, we are almost 100% that this patient will get better. If they don't, like I mentioned before, they'll come back if the pain persists or if it doesn't come back. And then the last part was about the COVID vaccine. It's a tricky situation because for as long as it's not yet mandatory, it is hard for anybody to actually say to the patient, you must have this vaccine before you come to my practice. So an ethical matter also arises where you cannot force the patient something that is not mandatory. So we would encourage the patient to visit probably a psychologist for that bit if they so wish, but we wouldn't enforce it on the patient to go that route. And then besides that, that's where we ended up before we got cut off. So hopefully
Okay.
makes sense. Thank you.
Okay, colleagues, thank you so much for your summing up. In your case, you did pick out the issues of patient autonomy. You picked up the issues of justice. So my point for all of this, as I summarize in the next few minutes, is that let's remember that this is Dr. Naidu in the South African Dental Journal in her ethics corner said that rendering good clinical care, in this case beneficence, requires effective communication. Failure to communicate can result in harm to the patient, and this in turn can have legal consequences. So in summary, we may be good in our clinical skills, but let's remember that patient factors play a big part in ultimately having patient satisfaction, and handling these two has to be within the context of those ethical principles. If we throw out ethics, then it really, really compromises us achieving patient satisfaction. And in conclusion, the application of principles of ethics may seem time-consuming, but it is worth the time and effort to help practitioners to have safer and satisfying practice. As you have said, I'm really sad that I didn't give us enough time, but we will have more time. I will speak with Dr. Vicky so that we have more of such sessions where we get practical and we help each other. So clinical expertise without ethics, it really compromises patient satisfaction. So coming back to my question, is ethics a private matter? I believe that the mouth, yes, the mouth belongs to the patient. He or she will use that mouth to praise you or to complain about you, depending on how you have managed them. And if you use ethics as the basis of your patient management, the patient will make this matter this private matter between you and them will easily become a public matter. When they are happy with what you've done, they make it a public matter. They tell others and draw more people to you. When they are not happy with what you have done, indeed it becomes a bigger public matter. So as I close, let ethics guide what the patient says about you. I really want to thank you, colleagues, and I look forward to us having more such interactions. And at this point, I will bring our session to a close. Thank you very much.
Thank you, Doc, for that. So we will proceed with the next lecture then.
Yes, I think we just need
a minute, right?
Switch. Are you ready?
I think we can proceed, and
yes.
if there are questions, we can do them at the end.
At the end, yes. Yes,
at the
that's
end.
fine. Okay, thank you.
All right, thanks, Doc. So our next speaker is Dr. Leonard Makoni, born and raised in Zimbabwe, involved in marriage and family support work as a board member and speaker with FamilyLife International. He's a counselor with Christian Counselling Centre in Harare, and he's also involved in one-on-one counselling privately as a volunteer in the Christian Counselling Centre. So there's a lot which is written there as well, and he's functioned as the managing director transformation team that has merged with the team advisory services to spearhead staff wellness programs under the name Team Wellness. This work enables him to work with local key industry players in executive coaching for team effectiveness, team building, and various aspects of soft skill development that enhance staff wellness. So I would like to hand over to him. He'll be speaking to us about grief management during COVID. Over to you, Doc.
Thank you so much. You need my video on. All right, let me try that. Good evening, and I presume you are, to some extent, most of you family in various ways. Thank you for allowing me into your space. Are we still going for 45 minutes, Dr. Vicky? Because that's what remains, or what happens?
Yes, you can just continue. We had a few, there's glitches which are beyond our control. You can proceed and let's see where we are at 7. But for now, you can go ahead and present.
All right, thanks. My goal is for us to look beyond COVID-19 adversity, to dig into our own resources such that we will thrive, to look for positives out of this confusion that we find ourselves in. Before we got into this space a couple of days ago, we requested that people participate in a pre-seminar survey. Confirm, Dr. Vicky, you can see my slides?
Yes, I can see them.
All right, thanks. And we had about 43 people exactly responding out of the 233 ZIDA members and expected 100 participants. And that was going to help us have an appreciation of who we are, how we are doing by looking at the mass burnout inventory survey in combination with Dr. Martin Shane's satisfaction stress offset score. And these are two tools we are going to basically use to get to a place where we say, what do I do now? The aim is to build an emotional wellness perspective to life, which then would help us to survive power cuts, to survive unethical behavior, to survive the pressures of going out into the world, which is closing out. But you have to come out for us to remain as healthy as we can be. So what we got was a 56% male response, 24 people, as compared to 44%, females. And of that age distribution, most of our people are 24 to 34. 7% of those being males and 16% females. We had just 156 to 65-year-old responding, being a male. Now, the distribution in regards practice, we have 30.2% of us in group practice. And that then means a lot of us are struggling to work as such in groups, whether that's positive or negative, is for us to digest through. But we will see, hopefully with time, to analyze this information and see what it means. Then distribution by years of practice, we'll see that most of us are within that 11 to 15 years of practice. That's 37.2% of the respondents. Whether that's because most people didn't respond or not, we do not know. But this is the representation of the people who are speaking to our situation as we go forward. Now, because I'm not showing in slideshow, you will see what you may not need to see. Don't worry about that. Skip. Now, we are coming in a global stressor called COVID-19, and our aim is not to unpack what COVID-19 is and what it's doing, because that is very clear to everyone. I think the summary was said last year, I can't breathe. We are human as much as we are practitioners, as much as we are healthcare givers. We face bullying. I think the previous speaker has indicated that there are some customers, oh, you don't call them customers, we call them patients, who come and they are aggressive. They know what they want. And you can be bullied by a patient. You are parents, and I pity a lot of you who need to be by the chair side, and still you have a child who needs to be helped with online schooling. Then you do face death. Yesterday I hear we had 25 new deaths. Those are statistics, but those are people, those are your relatives, those are your friends. And within the sector itself, we have lost doctors, some among us. That affects us, that raises issues in how safe we are to go out. We have extra demands for travel. Whether it's for you or for your staff or for the patients, it affects. Can you show us that you are essential service provider? Yes, it's less in this third wave, but you just don't know how zealous the next police officer you will face will be asking for that. That therefore means we have lost the freedoms we used to have. You could, without hesitation, leave your house right now, and you wouldn't bother that you are 10 minutes from a curfew. Then, of course, you fail to be heard. Yes, you work as a solo by and large, but there are many places where you are not heard as people who are either asking for service or you are giving service, you need to be paid. All these issues will add up to a lot of stress. And of course, you are still a human being. You are married, you have families, you have parents, you have siblings, you have in-laws. All those are issues that come. And as long as you are human, you are not immune to domestic violence, either to perpetrate it or have it perpetrated on you. So what this basically means is we have such a high demand on us from our, as somebody called it, a VUCA world. It's volatile, it's uncertain, it's definitely complex and ambiguous, but I add an H there, it's hostile. And if we have such high demands on us, with low latitude for decision making, there are very few places where you can make a decision because of the health issues, because of the economic issues, because of the political issues. That leaves us all distressed by and large. Now, I just need either you use your chat box or you can speak out quickly so that I know you are here. Otherwise, I'll wear my broadcaster's hat. I thought these could be some typical challenges you face within the sector, which demand adaptations. The first one I pick up is, in most places, they say, wear your mask so that we can serve you. The ultimate word a dentist will say is, take off your mask so I may serve you. Now, what other stresses are you struggling with? If you can use, please, the chat box. I just put here prompters, or you can speak out. We have debt collection, the new scheduling, constrained workspaces. What other stresses are you facing? Dr. Vicky, you might need to help me with reading them out because I really can't see my chat box at this stage.
Okay, someone said canceled appointments.
Yeah.
Great expenses.
Mm-hmm.
Debt collection.
Yeah.
Fear of getting COVID.
Yes. Real fear.
Staff safety and welfare issues.
I didn't hear that one.
Staff safety.
Yes, yes, real issues. How do you keep them safe? They are coming from a completely different direction. Some are using public transport. How can you control such a confused situation? Yes, anything else?
Lack of recreation.
Lack of recreation. Yes, you may want to go out, but where to? How many COVID tests do you need to take for you to be free to go for recreation? It may be demanded. Yes. What else?
Fear of infecting your family.
Major issue, and it relates. We have it here. We've got one boy who initially would say, "Hey, Mom, have you taken a shower before I hug you?" when she comes back. Real issues. Anything else?
Isolation.
Isolation, yeah. Real isolation. It's the real issue. And for some people, I've observed that after this isolation for so long, they're now afraid to come out. Anything else?
Death of a loved one.
Yes, death. Death is real. Death has never been as real as it is now. It could go on. The point is to reflect. So think about it. What stressors are you facing? And you'll see how that helps you as you go on. Now, this affects the team. And I've just put here 3 broad areas. You could come up with many others which typify burnout. That's the easiest way of telling whether things are well or not. When you can't carry on emotionally, physically, you are exhausted. You wake up and you feel like you've been running all night. And you hear yourself speaking negatively about anything and everything. You forget that it's a blessing to breathe. You complain about anything and everything. A loss of balance in life, you just can't make it. Everything is pulling you apart, and you know that's not where you want to be, but somehow you can't walk away from it. Then there's disengagement. You are not there with the work. It's now because I have to, I will. Because the patient has already made a booking, I shall. You force yourself to, you literally drag yourself to work. So you distance yourself from the job and of course, from the people that you intend to serve. I bet you those who do interviews or who talk to young people, why do you want to be a doctor? Why do you want to serve? Why do you want to be a dentist? And they tell you, I want to serve people. Now, when these issues pop up, you don't want to see people. Then, of course, there's team dysfunction, squabbles from nowhere. You wonder what is happening. There's no trust. There's no way that you can call each other to account. Problems come, you push them under the table and you behave like you are all well, harmoniously working, but deep down you're bubbling. Let something just slip and the whole place is imploding. And compromised professional efficiency, these are the things we're talking about in an ethical practice. I had to put that because I live with the person who was talking about ethical practice, but it does come in because you are compromised. You have huge debt on you. What do you do when that person who seems like they've got a lot of money is coming through? So you need to be careful when those things are happening. They may be speaking to greater issues. Then of course, low productivity itself is a major issue for a lot of people because they are not fully there. So productivity is lost. What does this therefore mean with our Maslach burnout inventory together with the satisfaction stress offset score results? The highlights are simply this. The percentage of burnout overall on the 43 respondents is at 56% low. So we're doing good. We're not that badly burnt out, but 20% is high. 20% speaks to people who honestly speak about their problems. So if you look at that moderate to high, you are within that 24 to that 40% statistic, which one of our psychiatrists here, Dixon Chibanda said, in Harare, out of a cohort, he did some work in 2014, 2015, 40% of us are struggling with common mental diseases. That's where we'll fit in with that moderate high. So the depression will come in, the anxiety to the extent of panic attacks will be there. So we need to watch out. It doesn't say we don't have low burnout. It says we've got low burnout. So that's the key to look at there. And now the largest group of us at 30%, 13 respondents, exhibit what they call depersonalization. When stressed out, they are mechanical about their work, no feelings for people, don't connect to people at all. Then 20% to, which is 9 individuals, show that they lack personal achievement. You're beginning to ask why you're doing what you are doing. Are you competent to do what you are doing? You feel unachieved. That's lack of personal achievement. And of course, it could make sense. Most of us are not very far from midlife crisis, so issues could be at play there. Then just 9% are talking of emotional burnout. That could be partly because we just don't have the emotional intelligence adequately. We hide away from our emotions. But whatever it is, we'll see in a moment how those emotions are critical for us to carry our world. Then the SSOS highlights are simply that disengaged among us is 23%. And borderline stressed out, you could go either way, to satisfaction or disengagement, dissatisfaction. It's 58%. That looks like a good result, that 58%. But the challenge is, it's just a question of a snip and you snap. Your emotional state then needs to be monitored very seriously. Those who had a +2, which is a score that speaks to satisfaction, was 19%. The graph here is speaking to the spread of that same borderline disengaged regards to males and females as compared to the totals. Sorry, is that a question? So it
No,
doesn't necessarily show any differences because our numbers are that low. We expect more of the males to indicate so. So that's not much of an issue. What really speaks to us then is what pushes us where we are solo practitioners by and large. The pressures don't come from outside because you are self-employed, so to speak. You have higher control of your work. You determine by and large how your work happens. So you will see that 60% of us are dealing with burnout that's coming from internal problems, work demands. We put that demand on ourselves. So we spend much time on our work. And this could be because of the structure of our practices. This could be an issue of skills. I don't remember, I went through a vet school myself. Please don't confuse me when you hear that title. So I ask people to keep it away. I'm a retired vet, but I don't remember a day anyone told me how to manage a business because I was going to serve farmers. They run the business. I didn't really appreciate that I'm running a business. So now when you sit down and you have to do the account, you have to keep the records, you have to deal with the statutory requirements, balancing the NASAs and the ZNARAs, and I don't know who else along the way, the lawyers that you may need to talk to. That can take a lot unless you have structured your business properly, let alone for you to be reading ahead, for you to be reflecting on your cases. So you're going to spend a lot of time where you expected, in fact, that the business will allow you time to relax, time to live your life. You still struggle with running that business. And then, of course, we have personal achievement demands because you want to achieve certain goals. You have a life you have set for yourself. You have basics that you hope to achieve. And of course, some of it could be pressure. We see you as a doctor, that immediately speaks to what we expect to see of you. So those are pressures which can lead you, therefore, to exert more effort than you ought to ordinarily. And that does take up mental fatigue as you do that work. And ultimately, we end up with burnout. That's how these two tests would work for me. If we had time and if people are interested, Dr. Vicky, we can discuss to have a thorough assessment. Typically, we don't use this for any studies, but for us to appreciate where we are as a community, as a cohort. And you can speak, therefore, to areas where we can come and take corrective measures. If we go back then to the details of emotional exhaustion scale on the Maslow burnout inventory, the telltale signs are these. If it's emotional exhaustion, increasingly you are becoming tired more quickly. Right? We all get tired, but more quickly you're getting tired. By 10, when you used to be standing up, working at till lunch, now you are demanding time out much earlier. Or it's even in terms of energy levels. So you pump up either some caffeine of some sort, some chocolate. I don't know what else. I heard there's one of us who loves chocolate as a dentist. And it could be some of those issues that are at play. And just watch out that whatever you are using to compensate for energy, you are not developing addictive behavior. That can cause its own health problems down the road. You are unable to bounce back. You know now you've rested, but getting back to the same levels and standards of work which you used to have will not happen. Time off won't work. Take weekends away, even if you were able to freely travel, you still in fact need a holiday after a holiday. Then emotionally, it means you are facing serious exhaustion. Work through that. Then the lack of personal achievement. How do you tell something is happening? Just watch out. Maybe you have realistic and expectations of yourself, or at times it's imagined that I haven't made it. So you are seeking to achieve certain goals, but somehow you keep pushing yourself. There is always room for improvement. You never feel it. So you'll see in a moment how you can work with that. Then, of course, you've got discontent with life. You are just not satisfied. It doesn't matter how much you push yourself. You don't feel you are rewarded enough. You're achieving enough. Then that will lead you to despondency. And for most people, depression, questioning the purpose of life. Why am I here? I chose a wrong qualification, a wrong career. You start changing careers, going back to school. I don't know what else you could do, but check out. It's a pressure that's coming from within you. Then they call this depersonalization. It's a scale that speaks to detachment to relationships. And this is not just relationships with your staff, with your patients, but it will get into society completely. You have no way that you can empathize with people. So when issues pop up and you have challenges, you are mechanical in how you relate with them. They are just dollars that come into your system. You are counting how many medical aid forms or how many times you have clicked the till. That's all you're looking at, not people with issues with life that they need to deal with all their own dreams. Then the relationships generally just drain you. So you are withdrawn from people. You just can't relate with people. Then increasing your cynicism, and that could be yourself or just the place where you are. And these are some of the things that then lead people to say, maybe if I change my environment, it will work. It may work in some factors, but you are the core. As they say, if you are a lizard in Zimbabwe, don't think that you become a crocodile elsewhere until you deal with your heart. It's you who carries that cynicism, that depersonalization, that personal achievement, that emotional exhaustion. Then, of course, you are eternally irritable, whether it's with your family, with workers, and some of these are situations which we then see on our roads, people fighting each other. So what do? We need to understand our environment. We need to have a look at what it is that working against us. Look for that sense of balance because we're going to pursue in a moment what we need to get to. So Harvard created this scale where you weigh down the things that are leading to distress, admin work, anxiety, physical isolation, as we said, grief, health, dreams, death itself, and many things you can put on that left side if you're looking with me in front of the screen. And you'll see that the positive outcomes are less. Therefore, the fulcrum will be tilted on the negative. How then do we turn that around? We need to appreciate that the state of well-being is where we want to go to. Without you, we have no dentist, you have no dreams, you have nothing to achieve. So you, number one, the doctor, the person we are looking at, who is listening to this, you need to pursue a place of wellness, which is not just having no problems with your tummy, with your mental, but all these things need to come together. Absolutely, disease is there, but beyond that, can you bring your spiritual, your physical, your mental, your social well-being into place? And for us, generally speaking, these are the components that have been agreed on, have been researched, and you will appreciate that there's a physical being in you, there's an emotional being, environmental, financial, occupational, social, intellectual, spiritual. Pull all these together, and please don't thrive for balance, because that never happens. Even if you die, you begin to decay. So you are ever having something that distorts that which you call balance. You're working continuously towards balance. Achieving balance is an impossible goal, and therefore you'll be very frustrated, if not depressed, with your life. There's something that is ever disrupting your pathway to balance, and that's the nature of biology. We all agree that homeostasis is not easy to achieve. Therefore, even at this macro level, know that you are ever going to have things that disrupt you. We believe that we'll be here, we connect, and we're running. And just within 2 hours, twice, we lost power. That's a disbalance that comes. But of course, create margin. Improve your working environment within the surgical, the surgery, the clinic that you use, the office that you use. And that means it needs to be livable. A lot of us don't fully appreciate that we literally live at work. We come home to refresh and go back to work. 2/3 of your life is going to be spent in that place which you call your clinic. Can you put it to the best level it can be? Can you feel comfortable enough, free enough? And I know resources are not adequate. And this is where we would need to pursue the issue of group practices, where we can put together administrative costs and create environments that are conducive for well-being. Then, of course, avoid isolation. Yes, you can't meet physically, but talk to somebody. Have someone you can share your challenges with professionally, and have someone you can share your challenges with at a personal level. It's important. For those who are popping up from school, look for a mentor to work with. For those who are mature, it's important for you to look for a mentee, because that process helps you to be serving somebody, serving community through serving a younger professional. Then, of course, a schedule with adequate breaks. We need to look into this, regardless of the cost of living. Now you are probably scheduling it an hour at a time, if not more, because you need to sanitize, you need to change your garb and all that stuff. Is that reducing your income? But of course, your income could be determined by what dreams you've set for yourself. So you need to start looking at what is it that keeps me healthy to achieve the long-term goals I have. Most of us are rushing to achieve goals which can only be achieved in 40 years within 2 years. You will break your heart. That's a given. Then, of course, take time off regularly. Even if you can't go to Vic Falls and Mana Pools and I don't know where else, take a walk in the morning. Sit outside, review the day by simply doing nothing. Close that phone and that gadget and that laptop. Switch off the television. Even if it's used as a way of, but just that noise, take it away from you. Be empathetic with patients, with those you work with, and some of them really become anxious. Work with those. Then resolve conflict productively. Don't try to run away from conflict. It's always there, but deal with it productively. And you can learn to do that. Care for your body is a priority. As I said earlier, what you feed your body becomes you. How much you don't rest your body becomes how much you are not rested yourself. And be gracious to yourself and create margin, set boundaries. It's okay to switch off the phone and say, Leonard, I don't want to talk to you. That's important to do, because without you, we don't have what we need to have in terms of oral health provision. Minimize impact of stress on your life. Now, these things are go and do. How do you do them? Our problem is not that we don't know what we need to do. Our problem is in this world, we don't know how. And I believe it's a game of skills. We need knowledge, we need understanding, and practice, 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 practice what you believe. And I'm going to leave us with this skills development for resilience framework. And it's ASK, ask. You come to a place where you realize you're burning out, ask. You come to a place where you're not sure what's happening, ask. What do I mean by ask? Acknowledge your situation. Acknowledge your state, your condition. Then with time, you will accept your responsibility for your wellness, regardless of the situation. This is very important. Most of us start off by denying that, COVID, there's no COVID. You are putting yourself in a situation which will cost you. Then seek out support and seek to serve somebody. Know your capabilities and know your limitations. Ask. So it's not enough to know. It's important to develop the skills. And that framework there, I believe, will help us. One of the first places we need to acknowledge and accept is that we have emotions, and our emotions are determining us, are pushing us to take certain behavior patterns because we have certain goals. And at the core of our goals are the issues of security, self-worth, significance. That question, am I achieving? It's speaking to self-worth, significance. It's speaking to whether I have security for my family, for myself, or when I die. Those are the basic things we are looking for. It doesn't matter how it looks like, whether it's the number of surgeries you are opening, the number of qualifications you are drawing to yourself, and have 3, 4, 5 titles which are qualified. All you are looking for is security, is self-worth, significance. And knowing and acknowledging that you are responsible for that, it will make a big difference. You also need to acknowledge and accept that events are neutral. COVID-19 is not the first time we have had a pandemic. No, it will come back again. There's nothing new under the sun. Whether you're going to have a violent patient or not, that happens. A driver who doesn't like how you drive and they can shout at you, that happens. The hearts of men are not well. So the events around us are neutral. You own your thoughts, your assumptions, your beliefs, your experiences. Acknowledge that, accept that. You own your emotions. And by the way, being angry, frustrated, anxious, depressed, it's physiological, it's psychological, it's a makeup of a human being. It's neither positive nor negative. You need to be angry when the issues around you make you angry. So own your emotions, but you need first to know those emotions, of course. Then once you do that, you own your choices. There's always a choice. If you don't process your thoughts, if you don't work with your thoughts and your emotions, you're going to react. And then most of the times when we react, we struggle with the consequences. But you can respond by calculated decisions to choose how you are going to work with that patient who is giving you problems, with that medical aid which is not responding to you, with that staff member who seems just to be dragging behind. You need to work with your thoughts, your assumptions, your beliefs, your emotions to make choices that propagate you, that move you, that progress with you to your goals. And how do you do that? A ruler of emotions. This is core. We are not expressing, understanding, working with our emotions as we ought to. Recognize what you feel. Is it anger? Is it frustration? Is it irritation? Is it joy? You need to know that. And when you do that, you understand what that emotion is speaking to. Is it speaking to a goal that has been blocked? Is it speaking to uncertainties into the future? That's anxiety. Is it speaking to a missed goal? Therefore, you are feeling ashamed or guilty. Is it speaking to a goal in your mind or even realistically, which is unreachable? Therefore, it's speaking to depression. You need to understand what that emotion means. And this is information which is all over. Then, of course, what you can't name, you can't deal with. So give it a name, label it, then start expressing it. Now you need to regulate so that you express your anger, you express your anxiety, your depression, your shame in a productive way. This is the pathway to emotional maturity. And there's no better place than under COVID to be able to be dealing with emotions which are negative. We see that. Emotions which lead us to negative choices on almost an hourly basis. This is why I'm saying beyond this adversity, we have a resource, and the greatest resource we can do is the practice of being rulers of our emotions. That then can help us to start, therefore, seeking out help. How am I going to turn the fulcrum towards me? If you know your capabilities, if you know your limitations, then you're able to seek out support, you're able to seek out to save somebody else. So we want to reduce the negative perceptions and increase those issues that bring us a positive outlook. Therefore, go and understand what gives you security, what gives you self-worth, significance in life. And that's a function of what they call executive decision-making faculties. And once you do that, I believe half of us can come to that place where we can be empathetic. We have known what it is to lose 2-3 people at a time. When a young person comes and they are struggling with an issue of running a practice, we have known what it is to juggle between not having money and having to borrow money to run your practice, or to generate money out of a good presentation. You then can help somebody. It's only the one who has known what it is to fall who can lift the person who is down. Empathy is lacking in this world. I say this and I repeat it. If we get empathy in the president's office, empathy in parliament, empathy in our political leaders, in our spiritual leaders, in our homes, this world will be completely different. And we need to learn that skill. It's not just to know about it, but it's to learn that skill. And this is a time to do that. So how do we go beyond this bridge? Ask and live in hope. What is that hope? Humility. It's only when you are humble that you can ask. You can go to seek help from somebody. You can tell your story, I'm struggling, help me. And remember, these are not issues I'm saying go and tell the whole world. No. By now, you need to know who among us are the people that we can trust with our hearts. And of course, when you're trusted and you have got empathy, you don't want your stories to go everywhere else. Therefore, you will keep the confidentiality that's needed and therefore help each other. Then you're open with each other. Look here, I really need help. I'm struggling in 1, 2, 3. You know, this I know I can share with you, because there are people who know a lot, but because they're not humble, because they want to be the only ones who are ahead, they will not share what they know with others. Together, let's persevere. Perseverance will develop a good character, and we will lack nothing when it has matured. And of course, let's enable each other. That's what I live to do. Ever since I left vet medicine, I realized that I was enabling farmers to make their living. Why should I work through the pig to enable a farmer? Now I'm doing that, working directly with the human being. Enablement is the greatest gift you can give anyone, and move on. So let's ask and let's live with hope and in hope. And I believe we will make it. It's not going to change very soon. And I like this little song here. You will look at the environment here. It's the least, of all environments to dance the way they'll be dancing. It's the song, the words that are in there are not even speaking to situation which anyone can celebrate. If you need to contact me, my contacts are there, but listen carefully. Those who do not know Shona, give me a call, then we can translate this song for you. But I leave you with this song. It doesn't matter what's going to happen. Between the triggers of stressors and the choices you make, there is you, your head, there is you, your emotions. It doesn't matter. You can still dance in the rain. You can still dance in this VUCA world, and we'll live beyond adversity. Thank you. Dr. Vicky, thank you. Dr. Vicky, are you still there? Tawanda?
Hello, Doc.
I'm done.
Oh,
Any
okay.
questions?
Okay, thank you very much, Dr. Makoni, for a wonderful lecture. I think Dr. Vicky has had a problem with the Wi-Fi. Do we have any questions from colleagues? People are appreciating a lot Dr. Makoni for the lecture. I myself found it very, very interesting. And I think we should have a lot of these lectures. They are very eye-opening, and we need to learn more about these things, which are secretly killing us from inside. I myself have experienced this burnout thing, and it has helped me a lot. Any questions, colleagues? It looks like we don't have any questions, Dr. Makoni. Thank you very much for presenting.
Thank you.
I have a
Sorry,
question.
am I unmuted?
We can hear you.
Hi.
You can talk.
I just wanted to mention one of our BDS 5 students will be sending out a questionnaire quite soon, looking at the effects of or the impact of COVID-19 on dental practice in Zimbabwe. So if you could very kindly fill in the questionnaire, because we're trying to look at ways that we can then approach people to help in the various sectors or give ideas. So for example, people were mentioning online learning and the financial situation as well, just putting heads together. So please, can you look out for that questionnaire? It's not very long, but please can you fill it in, and she'll then collect it. She'll be in touch with you soon.
Okay, thank you, Doc. Also, I was thinking the response to Dr. Makoni's questionnaire, as he pointed out, was not very good. About 40-something people or 50-something people responded. Is it possible to, Dr. Makoni, to retake that questionnaire if members are willing, so that we have more members responding to it and we have a more realistic picture? It would be good for us to know what is really happening and how we can be helped.
Can I respond after Dr. Chinara? Please go on, Dr. Chinara.
Oh, yes, Dr. Makoni, thank you very much. I really appreciate the presentation. You probably labeled a lot of things that we deal with without knowing what it is all about. And also you gave us quite a few handles. The question I have, you probably have an answer, but maybe not, maybe just for us as a community to ponder on it. You know, you mentioned there was your graph about group practice and solo practice, and most of us are really practicing solo. And I guess all the problems that we are relating to are emanating from that particular setting. And I was wondering whether you are aware, whether there's some data that's available which sort of gives a posture on what is a better environment to work in. I would imagine it's always a trade-off. Solo has got its own problems and disadvantages, and group practice might give you certain advantages over solo, but it presents new challenges, but sort of on a balance sheet kind of scenario. Is there any data available that tilts the scale one direction or another, so that people may ponder and consider these scenarios?
Thank you, Dr. Chinara. I don't have any data. What should I call it? That dipstick we have. I'll look more closely on how the burnout levels are really working out, where people are in solo or not, but also age in terms of just the age of the people who are in solo or in group practice would also be important. That's why really a broader response would give us more meaningful information.
I would imagine.
Yeah, so right now I don't have an answer to that. And as you say, there's always a trade-off. But again, it's those issues which, if we fish out, we're able to synthesize a process or a system or a structure that can help us all. The issue is there a way we can minimize the negative perceptions or the impact of how we are operating? And I think just looking at some of the administrative challenges which we go through as medically trained people, truly speaking, we need to bring in business management 101 into every medical school. It will make a big difference. Just balancing a book, just knowing what the statutory requirements of employing 2 people. You are excited about starting your own surgery, your own practice, but you don't have an idea where to, whether it should be structured as a partnership, as a solo, what happens at the bank, what taxes are coming in. All these things will keep you awake at night. And yet you need to be living a better life now that you have arrived at that stage.
Maybe if I can come in, I think there was a suggestion that maybe that questionnaire could, the link could be circulated again, and those who haven't taken can take. I think it will help us as a profession to know where we are and to respond to Dr. Chinara's comment. Yeah.
Thank you.
If I can also
I'll open up I'll open up the survey once I've been given the instruction to. It's not a challenge. Thank you.
Okay, Dr. Makoni, thank you very much for that excellent presentation. I mean, I don't claim myself to be balanced or anything, but I would say I think there's a general trend globally that working in group practices is maybe helpful in the long term. And this is what I just observed and read. It is a global trend towards consolidating practices into group practices. And I think it has been observed that that tends to ease the stress of running some of these businesses or these situations that we're talking about. Just an observation. I've benefited from it myself. I've never worked in a solo practice all my life. But again, I say it doesn't mean that I'm a balanced person than the next person. Just an observation.
Thank you.
Okay, any more questions? If there are no more questions, we can end today's meeting at this juncture. Thank you very much, Drs. Makoni and all colleagues for attending. Goodbye.
Thank you very much. Good night.
Good night. Bye.
Stay safe.
Bye.
Good night.
Thank you.
Bye.
Well done. Thank you. Bye-bye.